Okay, it's 3 o'clock. So welcome everyone to the PrEP webinar. This month's presentation is an introduction to dialectical behavior therapy and is presented by Sara Cordero Celso from Ancora Psychiatric Hospital. And I'm Jen Sperduto, and I'm joined by my colleague Dawn Reinhardt-Wood, and we are from the Rutgers Department of Psychiatric Rehabilitation. And our team, which was SPREE, is now the Institute for Inpatient Psychiatric Rehabilitation. So welcome, everyone. We're glad to have you today. Today's presentation is still an interactive presentation, and we encourage you to ask questions through the chat box. We won't be opening the mic unless Sara says so. So if you know, you know. And a recording of this webinar will be available after the presentation, available on the Rutgers website. And Dawn's going to drop a link in that the chat box for you. Also, at the end of the presentation, you'll get a link for a training evaluation. And in that training eval is a copy of the handouts. And also, if you complete the training evaluation, you can get a certificate of attendance for being here today. Quick disclaimer, as you know, the PrEP program, it's an online forum for a variety of topics related to the state psychiatric hospital staff. And while Rutgers and the Division of Behavioral Health Services are co-sponsors of the program, the PrEP webinars are peer presented. And as such, the content is independently developed by the presenter each month. And so the views and opinions expressed in this program are those of the speakers and don't necessarily reflect the views of the physicians or the entities they represent. So that being said, we are recording so that we can provide a recording of the webinar afterwards. And so I'd like to introduce you to Sara. So Sara Cordero Celso is a program specialist at Ancora Psychiatric Hospital. And I didn't know that Sara was a music therapist by trade, but she became involved in DBT about 10 years ago. She's responsible for implementing a DBT unit at Trenton Psychiatric Hospital and was the statewide DBT coordinator overseeing all of DBT in New Jersey State Psychiatric Hospitals, including Ancora Forensic Center. She's provided training on DBT at all the state hospitals for all disciplines during that time period. And currently, Sara continues to train and develop staff, as well as implementing new forensic behavioral units at Ancora Psychiatric Hospital. So welcome, Sara. I'm going to turn it over to you. Thank you so much for being here.
Thank you for having me. Hi, everybody. So I also just want to say before, it's not in this next slide, but this is just an introduction and a brief overview of DBT. Viewing this 1 hour talk is not in any way certifying anybody in being a DBT clinician, because in order to be certified as a DBT clinician, it takes a lot of time. It takes a lot of supervision. It's a lot. It's very intense. So with that being said, DBT is a type of therapy that is especially effective for people who have difficulty managing and regulating their emotions, otherwise known as emotion dysregulation. It helps people, it helps focus on helping people change unhelpful, unwanted behaviors and learn better ways of coping with their problems and their negative pervasive emotions. So in this webinar, well, I'm going to introduce you just to the basics of what DBT is, who and how it can help, its inception, and the foundation. And then I'm going to go into the modules and the components that are really important in running an adherent milieu or DBT program in a hospital setting. And in my case, it's always been in a a psychiatric hospital, state psychiatric hospital, or forensic state psychiatric hospital setting. Next slide, please. So at the completion of this, hopefully you'll be able to define DBT, what it is, and identify the modules and components that are involved in a comprehensive DBT program, and also explain what DBT looks like in a clinical setting. So DBT was developed by someone named Dr. Marsha Linehan, and she had been a former mental health patient herself, dealing with things like severe depression, suicidal ideation. And so she became a psychologist, and around the late 1970s is when CBT, cognitive behavior therapy, started to become more prevalent and more prominent therapeutic tool. So she wanted to use that to apply to women who were suffering from pervasive chronic suicide attempts and severe emotion dysregulation, suicidal ideation. So she wanted to see how that could help with these patients. And so her and her team collaborated and started this research, and they did start using the CBT on these patients, but they found numerous problems. Three in particular that stood out to her that they really used to structure the DBT program. So the first problem was that CBT really just focused so much on change that the patients felt very invalidated by just them, the therapist wanting them to change without anything else. And then the other part was, excuse me, that the clients would unintentionally positively reinforce their therapist for backing off when a difficult subject came up by showing anger or withdrawing or threatening to drop out of therapy. And then, so if the therapist did back off from talking about that difficult emotion or subject, then the client would show warmth. And so it didn't allow them really to talk about what they really needed to talk about or work on any kind of change. And then the third most prevalent issue was that the amount of issues and problems that the patients had and the severity of them really didn't give the therapist enough time to work on what they needed to work on. The session really they didn't have enough time to help the client learn how to learn new skills and really apply them. So that's where Marcia and her team started thinking about validation and dialectics and how they could incorporate that into the need for change. So that's what they did. Clients then had to accept how they were feeling and accept the fact that they had to change. They had to make changes, learn how to change in order to progress. So since its inception, more studies have come out. DBT is much more prevalent in working with a range of diagnoses: substance use disorder, eating disorders, mostly with borderlines, but it can help with a lot of different other things. And my one main unit that I developed was mainly borderlines and substance use disorder patients. And sometimes we had that hybrid in the comorbidity, because that's often seen in DBT, because it does help a bunch of, a whole host of diagnoses. So the environment is extremely important to the success of this treatment, and the environment includes everyone on the treatment team, the nurse, the HS staff, the human service technicians, human service aides, and the patient, most of all, they're all integral in the success of the treatment. And the staff are the key. They're on the unit with the patients the most. They know the patients the most. So they really need to know these skills in order to help the patients and help the program succeed. And that program, the whole package deal for the patient, is on the next slide that I'm going to get into. So the first component of the whole comprehensive package of DBT is individual therapy. This could be done once a week, twice a week, 3 times a week, depending on the time allotted by the therapist, the acuity of the patient, how much time they really need. And the therapy is organized into stages and targets for treatment. So the first target being life-threatening behaviors. The patient has to be alive in order to attend therapy. And then the second one is the treatment interfering. The patient has to come to treatment in order to benefit from the treatment. And then the third is quality of life interfering. So building a quality of life. In DBT, we call it life worth living goals. So part of that is a diary card that's given to the patient for individual therapy that the patient keeps throughout the week to track any suicidal urges, any happy or sad. It's very individualized. It could be whatever it is that the patient needs to track. And then that's brought to their weekly session or however many times they attend, and themes are brought out and issues are discussed based on what's seen on that diary card and what's been seen in the milieu. And the purpose of the individual therapy is to improve motivation and develop that relationship and really be there as a cheerleader for the patient. The next part is the group skills training, and this is typically 4 to 5 times a week. In the psychiatric hospital settings, it's usually about an hour each session, and there's homework in between sessions as well to continue to encourage them to practice with each other, with staff on the unit. And this is in order to increase the patient capabilities. The next part of the treatment is really important, the color system or the incentive system. This helps with our contingency management on the units, and it helps improve the motivation for the patients to practice, because on incentive-based units, the more you try, the more you earn. And you can earn privileges, you can earn credits to the store, you can earn trips, you can earn a lot of different things. Because you know, most of us have earned something in our lifetime, whether it be you know, graduation or getting our license, saving up for a house, and finally being able to buy our own house. For our patients, either it's been a really long time or maybe never have they ever worked for something for themselves and been able to achieve it. So the color system is designed to help improve that motivation in them and help them get some agency in their treatment. The next piece is EBP, which is, let me tell you now, DBT has a lot of acronyms. Most of the skills are acronyms. Most of the treatments are acronyms. So I don't expect anybody to be able to name all of those, but at the end, there is a reference site if anybody wants to look further into any of the skills or strategies. So EBP stands for Egregious Behavior Protocol. And this is in response to any serious behavior in order to help keep the unit, the patients and the staff safe, and to keep the structure in place. So when a patient has an egregious behavior happen, they are on protocol. And egregious behaviors are things like patient-to-patient assault, patient-to-staff assault, self-injurious behavior. It could be extensive property damage, but it's not something like he was being rude to another peer, or he was acting obnoxious. Those aren't things that are going to warrant the protocol. If, however, they are something that are getting in the way of quality of life as a third level target, third tier target, however you want to say it, that is something that can be targeted in treatment as a lower level target, and behavior change can be done on them as well. Behavior change can be done for any kind of behavior, really, but right here I'm talking about the egregious behaviors. So just real quick, on egregious behaviors, they get something looks kind of like this. It's called a behavior chain. A lot of different variations, a lot of different links in it. But what the point of this is basically to tell the story of what happened. And it not only just says, I did this, that's it. It tells vulnerabilities of the patient. It tells us if they can remember. It can tell us a trigger. It can tell us a prompting event. It tells us everything that happened in between, consequences, and then some. So then this, once they complete this, they can either bring it to their individual therapist or another clinician, or even to the treatment team itself to discuss what happened, and also come up with the repair, the correction, and overcorrection. Oftentimes, if a patient has been in DBT for a while, they can come up with their own repair, correction, overcorrection, but sometimes they will need some help from the team. And once that's completed, they can continue to earn their incentives again, because when they're on protocol, they stop earning. They're not with the rest of the unit. They're off to the side working on a behavior chain. So, okay, the next part is coaching. And anyone who steps on a DBT unit is responsible for coaching. And this is to help practice and master skills, not just for the patients, again, for the patients and the staff. And then the last part, which is very important, all the pieces are important, but this part is very important because consultation team and SES are wonderful, wonderful systems of support for the staff, and it helps increase staff skills. Consultation team is usually once a week, and it consists of all the clinicians that are delivering DBT, and they come together and they talk about their caseload and if they're having difficulties with any patients, if they're stuck, and all the clinicians can, they get together and they help. It really helps with burnout, because dealing with such pervasive emotion dysregulation and behaviors on the unit day in and day out it's a very high burnout rate for staff. So the team is very helpful, very supportive, and we get a lot done in those sessions and support each other. We also, there's like a built-in space for teachings if anybody has something that they want to teach. So that's for the clinicians. And then the SES meeting, another acronym, stands for Staff Education and Support. And this is for the floor staff that work with the patients day in and day out. This is for them to come and practice their skills and to be heard and to talk about their most difficult interaction during the week, whether it be an interaction with a patient or an interaction with a staff. And we talk about it as a group. We can role play some skills sometimes. Excuse me. But what is said in the SES meetings stays in the SES meetings, unless it is something that is obviously reportable, that has to be reported, or if it's something that they want an answer for from administration or some kind of suggestion. I've gotten a lot of really good feedback from SES meetings, and even made some changes to different policies based on input from the floor staff, because they have some really good insight. Before we go to the next slide, does anybody have any questions right now? Because I'm going to start talking about the actual structure of the unit and what it looks like a day on a DBT unit.
There aren't any questions in the chat yet, Sarah, but if
Okay.
they, I'll let you know.
So about the unit structure. So typically on a DBT unit, there's a certain wake up time depending on your unit, your hospital, whatever that may be. On Lazarus unit, a TPH, wake up time and coffee group was at 6:45. If you were up and out of your room, dressed appropriately, clean, whether you showered the night before or that morning, your room is neat, your door gets locked for the day, so you can go to programming, and then you can go to coffee group. You get a regular cup of caffeinated coffee. You can watch the news, you can socialize with your peers, maybe work on some homework from the night before, whatever it may be. And this group can sometimes have a little snack, not always, but once in a while. And caffeine is a very big motivator for a lot of our patients. So if they want to have it, they have to be up and out of their beds on time. After coffee group, they would go to breakfast, come back to the unit, and then do morning meds, whatever else they need to do. And then the team would go to the unit and have community meeting where we would talk about the weather, anything in current events, any community issues going on the unit. We would talk about the menu for the day, and then sometimes we would sing happy birthday if there was a birthday. Sometimes we would sing a song to a patient if they were being discharged or going to a unit, a less restrictive unit. Sometimes we would do like a thankful session where patients and staff could thank someone for doing something nice for them. I forgot to mention that each community meeting, each DBT group, each consultation team, each SES meeting, every one of those starts with mindfulness. And at the end of every community meeting, we would talk about a skill for the day. And somebody would usually suggest it, tell us what it's about. We could role play it. We could talk about how different times they could use it during the day. And then in the day room, we had a part of the wall that was painted in chalkboard paint. So someone was always writing the date and the skill of the day up on the board to be a constant reminder for them throughout the day that this is the skill we're working on this week or today. Once community meeting was over, they would have exercise group or behavior activation, and they would go walk outside if it was nice, or they'd put an exercise video on, or just some music and dance for a little bit, just to get them focused for the day and energized. So after that group, they would do their core group, DBT group or substance use disorder group, and then lunch. After that, they would have another group, substance abuse, or maybe a group off of the unit in the treatment mall that they had earned to go to. We also had groups like DBT for anger and anxiety, DBT for substance use. And so then throughout the rest of the day, they could, there were some other groups they could go to. If they did everything they were supposed to throughout the day, they could earn the evening incentive program. So they would have to be up and out of their rooms, go to all their programs, go to all their meals, not have any egregious behaviors, and then they could earn an incentive, whether it be bingo or karaoke, whatever that night was, they would get to go to that because they did everything they were supposed to do that day. During the day, when program is in session, the phones are not on. So the patients can't leave group to make a phone call or answer the phone. During group time, it's group time, and that's when they would focus on group only, not have any of these outside distractions. So that, in a nutshell, is a day in the life on a DBT unit. Obviously, it's a very simplified version of it, but there are a lot of other things that go into it. I just wanted to get that out there before I go into the next slide, please. So the research that I was talking about before has shown reductions in suicidal behaviors, intentional self-harm, aggression, violence, depression, hopelessness, anger, eating disorders, substance dependence, impulsivity, you name it. And then increases in adjustment and self-esteem. And a lot of that is coming from, them being able to see how much they're being validated and to see how hard they're working to change and make that life worth living. And everyone is on a good unit. Everyone should be aware of what the patient's goals are so that we can continue to encourage that and keep dangling that carrot for them. Like, come on, you're doing so good. I know you want to get discharged and I know you want to go to cosmetology school. So we got to keep, I know it's hard, but we got to keep going. We got to keep going. Next slide, please. Balance. The foundation of DBT is balancing acceptance and change. In order to live a happy, meaningful life, you have to accept things as they are, and you have to work to change to make it better, to get that life worth living that you want. And a lot of the change behaviors that we work on are using the BCAs, behavior chain analysis, skills training, exposure, cognitive strategies, and contingency management, which we get a lot of bang for our buck out of that with validation, which I'll get into a little bit farther. But the next thing I want to talk about on the next slide is biosocial theory. And the quote up there from Marshall Linehan is, the biosocial theory is transactional in nature and believes that two factors reinforce each other. That is, the higher emotional sensitivity a child possesses, the greater the likelihood of not getting validated from the environment, which then leads to even greater emotionality, thus emotion dysregulation. So the invalidating environment and inborn emotional sensitivity often lead to what we see on our units. And this is the story of how they arrived at that point. So the individual therapist, while working on commitment or pre-commitment with the patient, because DBT is a voluntary treatment. You don't just get put in DBT. You have to want to change, and you have to agree and commit to the treatment. So while the therapist is working on getting the patient committed to treatment, they're also gathering information from the patient, from the chart, and they're doing behavior chains on past suicide attempts. They're doing behavior chains on whatever it is, the behavior that landed them in the inpatient psychiatric hospital, because those are all the things that we're going to need to learn about, to target, to help the patient change those responses to the emotions. And then once we get them to commit, then you talk about your sessions and your treatment targets and things like that. But a lot of the patients, some of them are pretty easy to get commitment from, but others not so much. And Marcia's literature, there's a whole section on commitment strategies if you're having trouble trying to get a patient to commit. And another place to help troubleshoot that is consultation team, because everybody has their own experiences to share and help support their peers with. So, okay, next slide, please. Validation. Believe it or not, validation is one of the hardest things that I've found to train, because I think most of the time people just think, oh, I'm validating, I know how to validate. And a lot of the times when I ask people to give examples or role play, it's something like, oh, I like your shirt, or that's a nice purse, something like that. And that can be validating at a very low level. At the same time, what we're talking about for these types of patients is not going to cut it. We need to be more targeted. We need to be more authentic and show the patient that they and their issues or emotions or pain, whatever it is, are worthy of attention and valid. And working in the psychiatric hospitals, sometimes it's a little hard to find truth in the situation or in their perspective. But there's always going to be a little kernel of truth. We call it the kernel of truth in DBT, because sometimes they're delusional or psychotic, whatever it may be. You can always validate an experience or an emotion. So if they're scared of little green men running around their room at night, something is scaring them. And we don't have to say, oh, I see them too. We're not going to validate that, but we are going to validate their experience and their emotion. And in doing that, we're recognizing that those emotions all have causes and are understandable in a lot of situations. And like I said before, it helps us put that money in the bank for when we need to cash out later. And what I mean by cashing out is if you develop a rapport with a patient and you're validating and you're, supportive and consistent with that patient, if you need that patient to do something and 6 other people couldn't get him to do it, they're most likely going to listen to you because you've developed that rapport and you've been a validating, consistent person in their life. I've gotten patients to just get up off the floor because I have that relationship with them. I've been called to different units because they know that I can get that patient up, because I've been validating with them and genuine with them and on the same level as them. In DBT, there's no hierarchy. The therapist is up here, the psychiatrist is up here. Everybody's on the same level. And in validating, you have to be genuine, because if you're fake, they're going to smell it a mile away, because they're very good at that. And it can be hard to validate, especially when you're new to being mindful to it, but it is something that you'll be able to fine tune throughout time. You have to figure out how much to validate and when to validate and what to validate. So we're not going to validate invalid behavior. We're not going to validate problematic behavior that is maintained through validation. For example, a patient wants to go into restraints. So they do some really egregious behaviors, they get in restraints, and then someone comes running over to them and starts holding their hand and saying, "Oh my gosh, what happened? I'm so sorry, what happened?" That's very validating, and they're in restraints. We don't want to validate that they did all that, got in restraints, and now we're showing them warmth. So on a DBT unit, if someone is having a behavior like that and they're in restraints, we cut off communication. The only people that should be communicating with them are the doctor and the nurse. And it's not to convey warmth. It's specifically for logistics to, range of motion or water, medicine, whatever that may be. When they have become more regulated and are released from restraints, that's when they will get their behavior chain. And that's when you can start to communicate with them. But again, it's not with warmth. The warmth is what's going to come after, and they've made their repairs and they're exhibiting pro-social behavior again. And so validation is also, it doesn't mean that we're always agreeing with a person. So if a patient is mad at a nurse because they won't give them a boost when it's not ordered for them, and they start screaming and cursing at the nurse because they're hungry and they want their boost. Okay, so how are we going to validate that situation? How can we validate that patient when he doesn't have a boost ordered and he's screaming to high heavens at this nurse? We're going to validate that he's hungry. We're going to validate that he's upset. Right. We validate the hunger, but not the behavior. And this will often help diffuse a situation when we tell them, like, I get it, you're hungry, as opposed to just saying, no, you don't have it ordered. And that's just going to escalate the situation. So with clarity, precision, compassion, and this last one in bold, replace but with and. I still struggle with this sometimes. It is very hard to do. And it's very, very beneficial when you can do it. So if you're going to validate somebody and say, oh, you did such a great job leading mindfulness today for group. I really thought it went really well. It was funny and this and that. But, next time maybe you could try this, this, and this. So all that nice validation you did before the but, everything's wiped away because you're saying but. So nothing matters what you said before. If you say, you did such a great job with mindfulness this morning, I really liked the story you told, and maybe next time we could try it with a little bit of this. It changes how they're hearing it and how they're receiving it and how you're saying it. So just a little something to be mindful of, trying to replace that but with an and. All right, next slide, please. So these are the skills modules: mindfulness, distress tolerance, emotion regulation, middle path, interpersonal effectiveness, and special skills for substance abuse. Depending on the population, you might not need to use a lot of the middle path module. You might not need to use the special skills for substance abuse module. But with every, on the unit, we would start a whole new section with mindfulness. So we're going to start with mindfulness. We're going to do that for however long you're going to do it, a week or 2, 3. Then we're going to move to the next module, say distress tolerance. We will work on distress tolerance for a few weeks because it's got a lot of skills in it. After that, we're not going to move right to emotion regulation. We're going to come back to mindfulness because mindfulness is the root of all of these skills. You need mindfulness in order to be effective with all these skills. So next slide, please. What does mindfulness mean to you? I know when I first started learning DBT, I did not think mindfulness was for me. I thought it was like this hippy dippy waste of time and hokey pokey crap. And we would have to do it before meetings and in trainings. And I used to kind of half do it. And, if it was one with our eyes closed, I'd be looking around and seeing if other people were making funny faces, and I didn't really take it seriously because I'm like, I don't have time for that. I don't know how people can do this every day. but mindfulness doesn't have to be long, and it is something that you need to practice to get better at, just like anything, really. And so let me talk about some of the stuff that mindfulness is not, because when I often train on this, I'll ask people what they think mindfulness is, and 9 times out of 10, people that have no experience with mindfulness will say relaxation. And that can be true. Mindfulness can absolutely be relaxing, but it doesn't always have to be. And it shouldn't always be. You know, when I would run SES meetings, or even if I was running a DBT group, if I saw everybody in the group slouching in their chairs, half snoring, eyes closed, I'm not going to do a down regulating mindfulness. I'm not going to have them close their eyes and, you know, breathe in for 4, hold it for 4, exhale for 4 in a nice calm voice, because then nobody's going to be focused. Everybody's going to be asleep. In that case, I would have them stand up and do a Simon Says, or, you know, toss a ball mindfully in a certain order, something to get them upregulated and focused as opposed to asleep. Some more misconceptions about mindfulness is that it's just completely religious in nature, which it's not a specific religion, although most religions have an inherent mindfulness aspect to it. You know, Christianity has prayer and silent intention, and meditating on biblical passages, but it doesn't have to have any kind of religious affiliation at all. You don't have to be religious to practice mindfulness. And when we're doing mindfulness to, you know, to start a group or things like that, what we want to do is attach a little story to it, especially for our patients, because when they're practicing it on their own, they can connect it with the story and hopefully be more effective in practicing it. And you know, depending on the story, be more effective in mindfully doing this or mindfully doing that. Let's see. Okay, we'll go to the next slide, please. Just some more about mindfulness, because mindfulness is important. John Kabat-Zinn said, mindfulness means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. That one was also a hard one for me in the beginning, non-judgmentally. And being present in the moment without judgment doesn't have to mean, you know, judgment doesn't always have to mean being mean or being cruel to somebody, but or of thinking about something like that. You know, like I said, when I would do mindfulness, I would look at other people and kind of be judgy, but it's also about judging yourself and being throwing yourself fully into something, as opposed to being self-conscious and worrying about what other people are thinking, because then you lose out on the moment-to-moment experience. You're supposed to be doing one thing at a time on purpose. And if you're worrying about what other people are looking at or thinking, then you really lose out on what you're supposed to be experiencing. And who the hell cares what other people think? So some of the mindfulness skills that we teach are what skills and how skills, what skills are observing, describing, participating, like I was saying. The how skills, non-judgmentally, one mindfully and effectively. Then there's another one called wise mind, which we often refer to when patients are, you know, trying to make a decision or are in a certain situation. We talk about thinking about the problem in just logic or reason mind, and also thinking about the problem in just emotion mind, and what those things need to do to synthesize to come to wise mind. Wise mind is taking into consideration all of the things and then coming to a wise mind decision. Next slide, please. For some of the benefits of mindfulness in your personal life, improved focus and acceptance, which I can attest to. The active listening I can attest to, because I use it a lot with my husband, who's a plumber, that likes to tell me stories from work. And at first I would just kind of like blow it off and yeah, but learning how to actively listen, because he's my husband and he's important and his stories are important that he wants to tell me. I've learned all kinds of plumbing mumbo jumbo. I can, have conversations about J traps and all these other things and cameras and blow bags and this and that. And it makes a difference. It shows the other person that what they're saying is important and that relationship is important. It also helps with an easier transition from work to home and vice versa, because of the job that most of us do. And the clients that we deal with, it's hard. And so being mindful of that in and of itself makes it easier to leave that at work and leave that at home and just focus on the one thing that you're doing, either working or being at home and working for most of us. It's also good for wellness and stress reduction, and it helps us build resiliency so that we can deal with things and become like Teflon tough, where we just kind of let things roll off our back. We don't let the little things bother us. It helps with reducing negative health outcomes, because when we're not mindful of these things and we let that stress really build up, it can do a lot of damage, a lot of physical damage. Next slide, please. Okay, distress tolerance is the big one. This module, I think, has probably the most skills in it. Anybody have an idea why? Most of our patients with borderline experience things at such higher levels than us, right? So if a boyfriend broke up with them or a girlfriend broke up with them, it's the end of the world. So for most of our patients, I think they think they're in crisis all the time. And these skills are to survive crisis situations without making them worse, and also kind of being able to distinguish what really is a crisis situation. So we're not going to use these distress tolerance skills to solve our everyday problems. We're not going to use these to solve things like just everyday life things, right? This is for something that is short-term, high stress, that you need to fix it now mentality to become free of that suffering that those emotions and that situation is causing you. So for most of our patients, they are living in crisis mode often. And, because most of them have emotion dysregulation and they don't know how to control it or even name it. So I'm just going to name a couple of the skills, because there's, excuse me, there's the stop skill, there's the tip skill, and these are all, a lot of them, when you're working with patients, if you have that rapport with them, they're going to be willing to be coached. They're going to be willing to do the skill with you. And the pros and cons is another one, where in DBT, because we're extra, we like to have extra columns. So instead of just having a pros and a cons, we have 4 boxes where we talk about the pros of doing something, the cons of doing something, the pros of not doing something, and the cons of not doing something, so that we have even more information to kind of weed out some answers. Radical acceptance is a really great skill. This one has helped me a lot, and I know it helps patients a lot, but it's one that I think takes a little bit of practice, because radical acceptance is just what it sounds like. It's accepting the situation for what it is, not agreeing with it or liking it, just accepting it. Because if you accept a situation, it makes it automatically less painful. And so I've had patients that, their parents died 30 years ago and they still can't accept that, and they're still living with that. If somebody loses a loved one and just wants to lay in bed all day with their covers over their head and not partake in anything, it doesn't bring that person back, right? It just makes you more miserable. So you can accept that that person is gone and still miss them and still love them and still have a life. So radical acceptance, has helped me a lot. And you know, even the little things in life that are just so annoying that you could really like have steam coming out of your ears about, but you can't change anything about it. You know, there's nothing that you could do about it except accept it. And then you got to just move on. And it takes some work to do, but it's a good one. There's also some things like half smile, willing hands. And then there's another really long acronym called Distract with Wise Mind Accepts. And each letter of the word accept, ACCEPTS, has a different skill tacked onto it. I'm not going to go into all of them. But again, the modules have so many skills because DBT is not a one size fits all. The skills are not a one size fits all. So, you know, some patients may really like the tip skill and some patients may really like the stop skill and not like the other skills, or, you know, in distress tolerance. But that's what's so great about these skills. They can be layered, they can be interchangeable with certain aspects of them. So that's why, you know, especially for distress tolerance, for our patients that don't really have distress tolerance. Okay, next slide, please. Emotion regulation. The overall goal to this is really just to learn about our emotions and how to take control. A lot of our patients, especially with borderline personality disorder, in learning their histories and the biosocial theory, a lot of them were born into very, very invalidating environments and never learned how to cope with certain things, never knew how to describe certain emotions or even what they're called. So that's our job. We have to reteach all this to them and show them what emotions are and what your physical sensations, how they're manifesting into these certain emotions and how they manifest into certain behaviors and why. So this module is to help them understand and name them, decrease their vulnerability to negative emotions so that they're not all the way up here for a problem that's really should be about here. It helps them change emotions when they're not effective. It helps them manage difficult emotions when they do arise, because they're going to arise. And then for this module, we have, let's see, check the facts, opposite action, problem solving. And then there's another really long acronym called ABC Please that, you know, I am going to talk about just the please real quick, because for our emotions, so many different things can affect our emotions. And for the PLEASE, it stands for physical illness, eating a healthy, balanced diet, avoiding drugs or alcohol because they're mood altering and we don't need any more of that. Sleep, balancing your sleep because too much or too little is not good. And exercise to release those natural chemicals and dopamine and endorphins. So I just wanted to name those because it is important, especially for our patients who are on medications, who may be more sensitive to when they're sleep deprived or if they miss a meal. So this is a really important skill for them to learn how to balance those things. And just a little food for thought, when our patients say that, you know, their emotions, this is never going to go away, this is going to be forever. Most emotions only last 90 seconds or less. But to many of our patients that don't have emotion regulation before these skills, it feels like forever. So just a little. All right, next slide, please. Middle path. So middle path is really most popular with outpatient teenagers and families and teenagers for like family therapy type thing. I only included it because there were some patients that we've worked with in the past that were younger or had a lower cognitive ability or that had very involved families where we did bring in some of this work of the middle path and learning how to find that balance between too strict and too loose, you know, the dialectics in those relationships. So validation behavior change skills is really what we use here for the middle path. And we use it to increase behavior we want to see more of and decrease behavior we want to see less of. And just remember that two things can be true at the same time, because that's what the dialectics is. All right, next slide. Almost done. All right, interpersonal effectiveness. This is how we learn to interact more effectively with others, by asking for what you want, saying no to what you don't want, and maintaining your self-respect or values, building and maintaining relationships, or bettering relationships that you already have, and balancing acceptance and change in relationships. For a lot of our patients, they don't know how to say no. You know, a lot of them have been abused in a lot of different ways and have been taken advantage of in a lot of different ways. So for them to kind of find out what their self-respect and values are and continue to say no, is big for them. And again, this module has so many acronyms. Dear Man is a skill with every letter meaning a different thing on how to ask for what you want. And then there's Give Fast, and the give is for keeping a relationship that you have and making it better. And then the fast is keeping the respect for yourself in that within that relationship, whether it be saying no or whatever it needs to be. Okay, next slide.
Before we move on, Sarah, I just want to remind you it's 10 to 4.
Yes.
Okay.
I only have a couple left.
Okay.
All right, substance abuse. Again, I just included this one because DBT has been shown to be effective with patients with substance abuse, especially when they have the comorbidity. So they learn skills to help manage cravings and urges, build a new life, and avoid traps that can lead to relapse. The relapse prevention plans are developed with the therapist and the patient, and again, overlap the skills from other modules, like learning to say no and the ABC please. Next slide. All right, so we're going to help clients use skills and manage challenges. And these are just some of the things that we use on the units. Nursing management plans are very individualized for when patients are at a high risk of aggression, or if a patient has an anniversary coming up of the death of a parent that usually brings out some egregious behaviors. We get these nursing management plans in place. We train the staff on them so that we're more on top of things, as opposed to being reactive, we're proactive. Same with nightmare protocols. They're very individualized. Do some grounding work and routine work for patients for at night when they wake up with these nightmares. Coaching, phone and in-person, or etc. as permitted. Some programs do not permit patients to call, like inpatient state psychiatric hospitals, but in an outpatient, it's just general rule. They will call their therapist prior to acting on an urge to get some coaching. You must know skills in order to be helpful, and training as well as assessment of skills on the unit should be ongoing. And this is with competencies in the milieu, the SES staff education and support meetings when they're learning or practicing new skills. So that should be ongoing for all the staff and all the clinicians as well, to keep them abreast of everything. Okay, next slide. What skill do you feel most comfortable trying? Which skill feels like it may be the most challenging for you, and why? And does anybody care to share their experience in using a particular skill? I've talked a lot, my throat is dry.
There are no questions or comments yet, but if you have one, please feel free to type them in the chat. Sarah may want to hear your voice. I don't know. She'll let you know.
Willing hands. Yes, Gina. Love me some willing hands. And it's easy. You can do willing hands anywhere, palms upturned, accepting a situation for what it is. Mindfulness is the hardest. I know you hate the quiet mindfulness exercises, Gina, but you just got to practice some more. And then it gets a little easier every time. Oh, Mary George, mindfulness is your fave.
And there was a question, what was the hardest part about running, I missed it, running the units?
Hardest part about running the units? All the red tape within the state psychiatric hospitals, which did get easier as time went on, but I think consistency of staff is very important, and that can oftentimes be out of our hands. So trying to keep up with trainings and coaching on the unit and being present in the milieu while doing all these other things, even at other hospitals, was really difficult, but rewarding to see. You know, I have patients that have been out for 2 years that still call me on my work cell phone just to check in and tell me that they're doing well. Wise mind accepts. Yes, so many options to help handle the moment, Angelique.
Samantha noted that she has patients who use the skill with the water on the face. She said she thinks it's tip.
Yes. So the skills again are depend on what is available at your facility. Sometimes on units, they might not have access to ice packs, so they will use very cold water on the face. Some units will have that accessible. I know Lazarus, we always had ice pack. Well, for the most part, had ice packs accessible for patients to use whenever they needed it for a skill. It was very important for them.
And
I think there was another
Michelle-
question.
Oops, sorry. Yeah, Michelle has a question of what happens if staff don't quote unquote buy in?
If we'll get certain chances, a few amount of chances, but if it's them unwilling to change or learn, then they would have to move because they could sabotage the whole program.
And Chandra mentioned that she thought the hardest skill to teach was pros and cons at times.
It can be, yeah. It can be really tricky. But some patients really love it. So that, again, not every skill is for every patient. And for the pros and cons in particular, excuse me, I know a patient that used that pros and cons, that had it laminated and kept it with her in her pocket for times that she would start feeling dysregulated or feeling an urge, and she was discharged and would still, you know, have it in her wallet as a reminder. To each his own.
That's great. All right, any other questions or comments before we move on? Here are some of the references that Sarah's offered. And again, these handouts are available on the training evaluation. There's Sarah's information. And again, the training evaluation link, Dawn just put in the text again in the chat. And one more quick question. Do you have outcome data?
I just skipped over that one.
Okay. All right, never mind.
I was working on it, but thank you.
All right, well, it's 3:59. So thank you so much,
Yeah.
everybody, for joining us today. Thank you, Sarah, for your presentation. If anybody
Thank you.
get a chance today, get the training evaluation done. If you don't have time to do it today, as always, we send it out again in the morning. So if you can't do it right now, we'll send that out to you in the morning. So thank you, everyone, for coming. Thank you, Sarah, for presenting, and we'll see you all next month on June 20th for the next prep. Stay tuned.
Thank you.
Everybody.